Hello, welcome to this next episode of the Progressive MS webinar series, where we're trying to help you become more resilient in the face of your multiple sclerosis. So today's episode is how the carer can help the cared. And we've got Dr. Jonathan Egan with us today, who is a clinical psychologist. He is an academic and chartered health and clinical psychologist. He has also trained in both attachment and affect phobia therapies. His research has been in relation to trauma, its effect on a person's psychophysiological well-being. His other clinical and research interest is in how our own learned internal models of relationships, which we learn in childhood, can affect both professional caregivers and in people who are diagnosed with chronic health conditions, and whether they can learn to improve their ability to seek help effectively without shame in order to receive effective care and be met as a person who is an expert by experience in their own health status and needs. So thank you very much, Jonathan. Welcome again.
Thank you. Great to be here.
So I've been actually trying to think what is the best way of doing today's webinar, because I am a cared for person and I have a whole load of needs and wants that I want, but what is the most effective way for the carers around me, be it my partner, my friends, my family, what is the most effective way that they can help me with my illness? And I think there's a little bit of this is a tricky one in that I have needs that I want, but maybe it's not good for my carer to satisfy those needs. Yeah. And it could be destructive, and maybe we'll go through this. When I was trying to think of the topics, I landed on three different ones: the physical needs that we have, the mental needs that we have, and then also the medical needs. And I thought that that should really be a separate category. Now, we do have people who are attending this webinar, and I really would like, if there are particular things that are issues for you, that you put it in the question and answer or in the chat, and then I can ask Jonathan about those particular things. Do you agree with my three categories, Jonathan?
Remarkably, I do. And not remarkably, it makes sense. Certainly when I work with, say, chronic pain populations who would have people with MS or fibromyalgia or severe chronic migraine, we actually break it down into those three categories. So when you're seeking help, just to see the trees from the woods, we need to have a look at what your instrumental, we put in, physical needs are, okay, what your mental emotional needs are, and then what your medical needs are. And we have separate training half days on each with the group, and getting the group to, well, the group really give the answers, really, don't they? About, okay, and to think in a less frightened way about these things, to have a creative place. When we're frightened, we just think black or white. We think no pain, no fatigue, to a place of safety. That's all we think about. So when you get a group of people with MS or fibromyalgia or any kind of chronic condition, when they ease into it and go, oh, okay, and they hear someone else, I never thought of that because I couldn't have thought that way because I was frightened, or I was in the grip of a very tense situation, or I was worried or catastrophizing about my MS, that I suddenly had a flare and I was going in the wrong direction. So yeah, those three things are really useful ways today to look at our physical needs, how we ask for those to be met, our mental, emotional needs, and our medical needs.
And which do you think is the best one to kick off with?
Well, we always wait when we do trainings with people to about the third or fourth out of 8 sessions for these ones, because these are the ones that frighten people. Okay. Because it's really hard to ask for our needs to be met, and to identify which person is going to meet those needs. So by you doing that, by bringing it to the three categories, we can safely explore each one. Otherwise, I think it'll be overwhelming for people to think about it.
And it actually, I find it very hard sometimes to say what I actually need. And this is interesting. In our last episode, we were discussing how I felt fear and anxiety. I was in a very bad place. Yeah. And the mood that I was in colored everything that surrounded me. Yeah. And I could not disassociate my anxiety and my fear from the practical things that I had every day. So the physical needs that I had, I stopped exercising. My diet went catastrophic, right? You know, my partner was there trying to bring me back to the center, because I had obviously, the pendulum had swung into this negative space.
Yeah.
How can a carer drag you back into that?
Yeah.
Like simple things like exercise, like you just don't feel like doing it.
Exactly.
So how can the carer overcome that?
So it's relatively easy. Obviously, if it's me with a person I'm working with, I can say, I think I'm losing you. Are you here? And I wonder if you're in the grip, you know, if you're in a place now that it's when the kind of the escape feelings occur. You know, we want to get into, just give me the answer now, just get rid of this awful feeling. It's probably the ventral medial prefrontal frontal cortex, which is connected to your amygdala. So it's probably one of those overwhelmed with emotional reasoning. You're in emotional reasoning rather than in the dorso lateral prefrontal cortex with the amygdala, which is the calming, where we're in a good place where you can actually calm. A bit like when I get a revenue letter in the post. When I see it now, I just go, Jonathan, just calm down. This is probably just something they're clarifying or something. You don't have to worry. And I calm myself now purposefully when I see a letter, let it come in. But if I had already come in and just got a speeding ticket, a parking fine, something else, and I ran out of petrol, I'd be in that other place, that emotional, reactive reasoning place. So what we can do is by meeting the right person and looking them in the eyes, and slowing down. I just got a message from you. Is that me to stop there? Is it? Or
no, you're fine. Yeah.
Okay. Is the way the brain works at a social level is by eye connection. If you go diving with somebody, you won't dive deeply with somebody you don't trust. Okay. So when we get into that fearful, where the breath needs to be controlled, where our movement and to stay safe needs to be controlled, we need to be identified as you're in distress, or to let a person know you're in distress by someone who you go safely diving 50 feet with. Does that make sense? So someone who can make the eye contact with you and go, gotcha. Okay, you're flailing a bit here.
See, and I think I've strayed into the mental bit a little bit here, but I think, I understand that, you know, you have to have that person with you who understands you. Yeah. And that takes years to develop that relationship, to develop that trust, as you say. And the one aspect that, you know, I need to exercise, and I've got my exercise equipment here, and I do my very best to do it. But there are times when I'm tired, or when my energy levels are low, and I find it difficult to do that. Now, my partner then comes in and says, Robert, you need to exercise. You know, the physiotherapist says it, the doctor says it, you know, it's good for you. Yeah. But the problem is sometimes that push that the carer gives you to do something. Yeah. There's a border between what is okay, and then it pushes over the line, and suddenly you feel, God, you're overdoing it. You know, this is my body. Mm-hmm. I know what I can do. I know what I can't do. Why are you pushing me so hard?
Okay. So that's, in other words, that's intrusive caregiving. If someone comes in too hard for us. So it's about, where is the line between, and it's something about being able to articulate to the person, not right now, not a good time, I need space. And then to have, because we're effectively in a flaring place there, aren't we? We're in a place of no return. So it's about saying, okay, and you have to have a plan there, which is, I'm going to set my watch for 40 minutes for an alarm. I'm going to go lie down in a dark room and do nothing or look at the phone, or whatever I do as my rebooting process, and then evaluate again 40 minutes later.
Okay.
You might not be in the place, your brain might be in that dorsal vagal area of the brain, the non-myelinated of the brain, where it's in shutdown. And you have to decide whether, okay, if I get in early enough and I know I'm on the way to shut down, get into some exercise and do something which will stop that going into that shutdown place. But otherwise, to respect the shutdown is needed, and then to say, okay, but set an alarm, and then what the first thing I would do is X, Y, and Z. And to change, when we're in that flare place, we need to change our expectations. The walk needs to be a half of the average walk we would do. So if you imagine the last 4 walks you've done, divide that and get the average we've managed that week, and then divide it by half.
And is it the carer's responsibility? Is it my responsibility?
It's about both, really. It's about both knowing each other. It's a bit like the heart and the lungs need to work together.
Okay.
So but it's about a conversation before the flares, and it's about saying, okay, this is what we need to do when this happens, and it's going to happen. Please don't follow me around saying you need to do exercise, you need to do exercise. I will need to just take some time out, come back and see if you have to figure out how long is the downtime you need. Some people, it's 20 minutes anymore, they go to sleep and they're gone for the day. But we do know from sleep and circadian rhythms, no more than 30 to 40 minutes, because you'll go into the next stage of sleep and then you're going to wake up absolutely wrecked, and you feel like you're drugged. So it's about managing, having a plan really, and knowing what it is. So I get up, I take a stimulant, a coffee or something that will help me. Or before the thing, have a coffee, then take the way they say about driving, to treat yourself that way. To not go into self-shame and kind of go, oh, I'm a horrible person, look at the way I barked at my partner. So it's to get ahead of the bark and go, look, I need some time. And that'll be agreed that you're able to go to your room and do that. So the person isn't tapping. And because I just get angry if that was me. I just want to shout and sandwich at the person.
One of the people who was attending here has said, my carer looks after me wonderfully, consistently and unquestionably.
Yeah.
My issue is guilt. So do I deserve this? Shouldn't I be doing more? How do I address that? And absolutely 100% I get this, because I used to cook usually in our house, and now I can't do it. I'm not as capable of doing that anymore. It creates all sorts of issues for me. And I have this guilt feeling of, I used to do that. I used to be able to do it. And now this person is doing it for me. And is this connected with dependence? Is it, why do we feel this guilt? And how can we overcome that guilty notion?
Yeah. So when guilt is present, it means we're in an inhibited place. It means that we are annoyed at ourselves or angry at ourselves or feeling shame about ourselves, that we're not able to be what we used to be, or what our deal is with our partner, our lover, or our friend. So what needs to kick in here is self-compassion, and that you have to learn that, you have to practice that, because that inhibition and guilt will get in the way of the relationship. It will actually get in the way and it'll ruin a relationship. It's like a slowly ticking time bomb. And your own anger will turn it into yourself. What will happen is you'll start to withdraw a bit, your mood will go down, and you either get anxious or mood, or you'll start to rely more on withdrawal strategies. And because you'll feel less worthy of yourself, and you'll feel less of a provider, less of a valid human being. You'll feel invalid in that situation.
And is there something that the carer can do, mm-hmm. or say, that would help us feel less guilty in that instance?
I suppose you're testing a mind read, really. It's kind of saying, I feel really guilty when you do these things because I used to do them myself.
Okay.
I bashed myself in the head because I should be doing these. Albert Ellis, back in New York in the 60s, who would have been around with Tim Beck, the kind of CBT founder, he was very funny, kind of tongue-in-cheek guy. He'd do therapy in front of 500 people in an auditorium in Stony Brook in New York. And Ellis would say that we're masturbating here, that we're going into I must, I should. So this is a case of masturbation. The problem with masturbation is it's circular. It goes in a circle and often doesn't have somebody else come in. It's a bit like a little boy or girl going to our bathroom or our bedroom alone, grumbling, and into a ruminative cycle. So by discussing with your friend or partner, whoever it is, or your GP, going, I feel like I'm wasting my time with you coming in, you're not going to be able to do with my MS. but I still have care needs. And putting that out there, and the person will go, God, no, you've got MS. You need to have medical professionals. You need to have me as a partner. You need to, it's a form of shaming yourself, isn't it? It's kind of
see, and that becomes really difficult because you're not the person that you once were, and you're becoming more dependent on other people to allow you to do those daily functions. And I'm even thinking things like food preparation, but take, for example, if you have children and they're young children and they're your kids and you want to look after them, you want to be an active part of their lives, but because of this illness, you don't have the same energy that you would need to, say, go out and play football or attend, say, a play or something like that your child is doing. And then you feel guilty because you're not being the good parent. And is there a role for the carer in helping with, because that's a huge challenge, the parenting issue?
Yeah, it's also because when we're in guilt and shame, it's very hard to think laterally, to think in a very divergent way. So I remember working with a chap who was post-stroke in the Mater, and he was in his 70s, and he was absolutely obliterated because of the fact he couldn't play golf anymore. That's what he used to do every day with his friends. And his vision in one quadrant, he couldn't see where the golf ball was. So, and he was frightened. So we had this conversation, and over the conversation, I asked him about his values. What were the values about the golf? And he says, well, he loves the chat at the end of the golf. And he loved, playing golf, but he wouldn't have the energy, he'd be too fatigued to play golf. So I said, was there any place you could meet your friends somewhere on the course? And he went, yeah, on the 13th or 15th, I'm able to go down and on a buggy and get there. I said, well, what about playing 3 holes? Would you be able to manage that? I probably could. It probably wrecked me, but I could do that. And then if they phone me, I could buggy down and then I could have the conversation afterwards. And he started doing that. And it's a different way of looking at, a bit like with the children in a play. For children, all they need is the 2 glances at some stage. Have a chat with the teacher and say, when is Johnny going to be on? I have MS, I won't have the thing. Oh, come in at half time. In fact, you know what? Why don't you come to the backstage bit here? And just as he's gone on, you can give him a wave. So there's lots of different ways we put ourselves into turmoil when there's actually lots of simple ways. What we need to do to look at those simple ways in a creative place rather than in a fearful place. Rather than I'm a bad father, I'm a bad mother. How can I cope? And it's a bit like meal making. It's something like, making a pancake mix on a Monday and using it over 3 days. It's about this, and having meals prepared. It is a planned life. It is a 30-minute life. That's the acceptance bit I think we're getting to. It's a different life. It has to be all planned in the units of energy you have.
And this is, I often say that we're playing a different game to everybody else.
Completely.
And we have a whole different set of rules. And the difficulty is over time is that game keeps changing and the rules keep changing depending on how our illness is progressing.
Did you see tennis, Robert?
Pardon?
Did you see wheelchair tennis in Wimbledon?
I didn't watch it, no.
For me, that was just an example of lateral, creative thinking. These people obviously had spinal injuries, and their legs were, atrophied. But they were out playing in Wimbledon. Tennis is better than most semi-pros could play.
And it is this ability to think laterally.
Yeah,
I think that is so important to focus on what we actually can do rather than looking at the things that we've lost.
Yeah,
and that is a huge challenge. I know for myself. Because you're continually thinking, oh, well, I used to be able to do that, and that was my way, and I'm being blocked from doing it because of my illness. But also, sometimes I could feel blocked from being my true self because, say, my partner or my caregivers want me to do something different or do it in a different way, and that's a conflict that we can set up between ourselves and our caregivers. how do you overcome that challenge?
Well, I think you tweeted one of the Confucian statements or something, because I do notice when people get into a chronic illness situation, when it could be progressive, is that they can live in the battle of the old self and the new self, but separately also at the same time use a lot of energy in the future self, catastrophizing about this horrible end position and losing themselves in the middle. They're not actually present to anything around them. And it's a horrible conflict, isn't it? That's there, and really were very frightening. But it means that the bits of beauty of life that's around, that sounds a bit cliche, but the reality is that doesn't get processed. You're actually living in the past and the future and not really living in the present. I can't remember the actual quote, but it's similar to that. And so there's something about slowing yourself down and catching yourself going into the future planning, the future reading, and also going back into the Apollo Creed, the second movie, where the coach says to him, you need to box in the mirror. And he says, why? Because the only enemy you have here is yourself.
And this is, I think this is the big thing that we have having an illness like this. It is that mental picture. And, we have an image of who we would like to be, and we have that image of who we were, and we're continually striving to be one or the other.
Yeah.
And we're forgetting who we are today.
Yeah.
Just to paraphrase what you're saying. And I've practiced at this, and thankfully I've got people who kind of, kickstart me or push me into a direction, right? But how do you make sure that you're pushing yourself in that right direction to stay in the now? And what can your carer do to kind of gently push you into that way?
Yeah. So the first thing we need to ask ourselves is, we should first of all do a litmus test to see, are we in the now? Mm-hmm. And by being in the now means that we're breathing diaphragmatically, doing the kind of bigger breath out than in, that we aren't jumping around in thoughts, that we've slowed right down, and that we're not eager to go into any compulsive behavior, whether it's compulsive eating, compulsive exercising, compulsive shopping, compulsions, anything that you feel I have to have right now. For some people it might be cigarettes, some people it might be a drink. Any kind of that means we're on edge. That means we're in the grip. We need to do strategies, obviously, to bring ourselves out of that if we are in that place. So to know we're in the here and now, then that's the good place of the conversation about the future and the now, what your needs are. If we're in the grip, we will tend to go to the wrong person for help. We'll often go back to the person who didn't give us help before, or we'll go back to the inadequate GP, or we'll go to the person and get into almost a battle. And when we're frustrated, we often want to have a fight to vent the frustration. So we'll find ourselves getting into that battle with the specialist nurse, or with the consultant, or those things, or people online, even on MS. These people who get them out. And I've trained a number of psychotherapists in Sweden recently, and these are psychotherapists who should be good at expressing emotions, what their needs are. And the first question on a consultation I'll say to them is, what do you need from me today? And the fear that raises in psychotherapists in Sweden is massive. Yeah. So can you imagine, and these are people who aren't in a fear state, okay, they've been evaluated, so they're frightened. So in other words, we have to learn the language and practice saying, what I need is this from you. And really practice. I remember when I've got clinical trainees with that, I'll say, what I need from you now, Robert, are the following. These 4 things I need. And I make sure you understand each of them. So it's coming across as an assertive place, but not aggressive. And say, these are the 4 things I need to explore with you. And they go, okay. And it's suddenly they're locked in. And they know that this conversation is going to last 4 sentences or 4 needs. And they want a discussion to explore it. What tends to happen is, if we're not used to this, is it comes out like a machine gun firing everywhere, or it comes out as an inarticulate range of mumbling statements, which don't make a lot of sense to yourself nor the other people. Then we get frustrated that other people aren't meeting us at where our needs are, because obviously we feel so much that it should be bloody obvious to anybody what my needs are right now. And often, if you've got an acquired illness which starts as progressive, you didn't want this illness in the first place. This wasn't on your map. Whereas if you started with, say, diabetes at the age of 6, you're going to be much better at using words to say what my needs are in the situation. So you're saying I want needs a bit like a slave to the owner of the farm. You're coming in from a place of submission. So it's about getting yourself and all your authorities from a body level to sit up and take up as much space in the room as you can to make your breath regulated. And what I would always do is, right now I've got this in front of me, so I have an external support. If it's a medical situation, it's one of the 3 places. It's to have a person to go in with you if you don't feel in a supportive place, so you can be regulated by their eyes or that, but to keep it yourself, that you're the person who's articulating your needs and having a supportive person there, instead of going into the wheelchair position, I call it, where the person suddenly is infantilized, and the other person that's present becomes the translator or some bizarre position. So there's something about getting that supportive place. Also planning the time of day you're going to have any conversation about your needs. That I'm not a morning person. Are you a morning? You're more morning person, Robert, now than
I'm a midday person now.
So that's why we're doing this now, isn't it?
Yeah.
So you're being clever in that way. But other people actually upskittle themselves by putting themselves in the wrong time and day with staying with the same GP for 15 years, who's absolutely useless, who isn't listening, who isn't caring, hasn't gone off and done extra reading about MS if they haven't done it, hasn't done CPD credits. And there's something about you're undoing yourself, and you're not being fair to yourself by not going to people who will have adequate enough skills to understand your situation.
One of the attendees has asked this question. When my husband comes in from a busy day's work and he asks me what kind of day I had, I sometimes feel that his eyes glaze over because my day is so uneventful. Okay. This is probably not the case, but I just say fine now, and this takes away any hurt I feel about this.
Okay, wow. That's fascinating. So you have a person coming in the door after they've done the fruitful day of providing, and come in to see the person who's not done very much in their perception, but maybe they've done lots, but there's a self-fulfilling prophecy that his eyes are going to glaze over. So I won't look up and assert myself in I need a conversation now. So it sounds like a bad time to have a conversation, a bad time to say, but it's about planning, a bit like what you said earlier, when you have young children, when do we plan conversations? And it's about getting the right time for both. If one person's a morning lark, one person's a night owl, about saying, okay, when do we meet? When do the ships pass, and have the conversation? It does sound like if that was me, I'd be quite lonely. And it might be that that's what really happens. It's one of what's avoidance is loves, anxiety loves avoidance. And part of anxiety is this shaming and this self-rumination. And it's really effective immediately. We go, oh, phew, I didn't have that awful conversation. So we start to avoid more and more. But we end up being very lonely. And then when we get lonely, our immune system goes down, our energy goes down, and our vitality goes down because we stop having shared lived experiences with other people. So it's a dangerous place. And I'm reading into the place, but for the person to really think about, okay, how can I have a more authentic relationship with this person? When can I talk about it? And add in, honey, I'm quite lonely here.
Okay. And that's a really hard conversation to have.
Very hard.
And I know myself, there are certain times of the day when I cannot have that conversation.
No.
Okay.
No.
So I cannot have it in the evening. Anytime after like 7:00, my brain is not functioning properly.
Yeah.
Same with early morning. It takes a while for me to get up into gear. By the time I have my breakfast and have my cup of coffee and slowly incorporate into the day. So you've got a limited time. And say, for example, in this instance, there are partners out working during the day, let's say Monday to Friday. That means this conversation about how to deal with it has to happen on a weekend.
Yeah.
And it has to happen at a time when both people are in a position to really have that conversation. And that there's no negative association with that chat.
Exactly. And I remember talking to a sex therapist once, who was I think a psychosocial sexual therapist. And she's saying the quality of a conversation often relates to the quality of your sexual relationship. Now, and she didn't use sexual relationship. She used the term sexual affection, because it could be a kiss on the cheek, it could be just a rub in the face when you're in bed, it could be holding hands. That could be the sexual connection. It doesn't have to be the procreate kind of and have orgasm.
Mm-hmm.
It could be just that gentle touching, the gentle meeting, the hug, the moments where you catch the person's eyes, and you go, ah. And that's all affectionate sexuality, she called it. That's hugely important. And that, she says, that often relates to the quality of the conversation people are having about where they are. If you think in your mind from 0 to 10, how connected am I to my partner? And then if you did it twice, there should be a fairly high correlation between sexual affectionate sexuality, which could be a cuddle, could be holding hands on the couch.
And this is a really real issue for so many people. When I know myself, my libido can drop.
Oh yeah.
Right? And because of either loss of sensation or fatigue or the time of the day, or my brain is thinking of something else and my anxiety is going through the roof or my stress is going through the roof. So anything to do with physical contact or affection suddenly becomes a challenge, because I'm thinking in my head all the time.
Yeah.
And I need to get out of that and to connect with my partner. And it is this cognitive problem that we can have when you have progressive MS, is to get those words out. Like I had an experience there a couple of weeks ago, and I was under a lot of pressure, a lot of stress, and I was in a conversation, and there came a point when the words were in my head, they were there, could not get them out.
Yeah.
And that creates frustration, creates anger, but it means that you can't have that real conversation.
Yeah, no. So it's about saying, oh, I've hit my limit, that limit. And then the person go, okay, we have to come back to this again. It's a bit like wanting to have sex when the kids are around. Suddenly they come in, you're told to stop this. We just can't do this right now. It's not realistic. So it's and that's about the difficulty there is you don't go bash yourself over the head afterwards, and give out to yourself and go, oh God, I've done it again. That's where the self-compassion, I think, is huge. And it might be really interesting if you got somebody in on your webinar as a self-compassion expert, because it sounds like it seems to be that you're identifying a big issue of people being self-compassionate to itself in the context of a chronic illness, which is for half the audience today, which is progressive, and for the other half don't know if it's going to be progressive. That fear that's ongoing, and in the affectionate sexuality side, when there's fear present, that's going to affect everyone's sexual quality, no matter what. Because ongoing fear, it's a bit like Billy Connolly saying that it'd be funny if we actually got erections as men. And when we're frightened, because your wife could say, or partner, male or female partner, could say, I know you're feeling very anxious. And they go, why? Because you've got a raging erection. But the reality is, for men and women, when we're frightened or ongoing fear in the background or stress, it just cuts off the flow down to the pelvic area. It's going out your arms, your legs, you're fidgeting, you're moving your head to think.
And see, then my fear is that the relationship, if you lose that intimacy, and whether it's just a touch or a kiss or that hug, if you start to lose that intimacy, the relationship changes from being one of lovers, let's say.
Yeah, I'm getting the fear feeling all over my body now. It's really frightening, isn't it, the vista?
Yeah, and then you become, it's like a nurse-patient relationship.
Yeah.
And how do you overcome that? And I think once it gets into that, it must be very hard to recover it back to that relationship, that human relationship.
So a good nurse-patient relationship is better than a dominant submissive relationship, where one person goes submissive and the other person's angry and dominant to the other person. So we try and differentiate the different types of things. So what we really want is a relationship where we can be authentic and assertive about our needs. And that's the conversation we talked, I think, last time about saying, well, I have instrumental physical needs. I need help with the shower and I need help with making food. And can we plan that a relationship that we get those, and I can do this bit and you can do that bit. And outside of that, the way I'm going to call you if I need help is the following. I'll state this. So please don't ask me. I will let you know when I need help. That's really hard for people to do. You know, it's not easy, because the ideal place, and it sounds like the person who wrote earlier, could be in one of those, which is really unusual, these relationships where the person implicitly knows without even having to use words. But for 90% of us, we need to use words, because we go into mind reading otherwise. And when we go into mind reading, that's fine if we're in a really healthy place, because often, 70% of the time we'll get it right. Mm-hmm. But if we go into a place where we're a bit anxious about our relationship or the other person, or if we're a good enough partner, if we're a burden or not, if we're providing, we'll start to distort ourselves, I think.
And I think that one of the aspects that I've noticed is that the psychological support that people with MS get is very poor. We don't have that teaching to help us to prepare adequately for how to have a relationship when you have a chronic illness. And so you end up, reverting back to like how your parents treated you as a child, or how a teacher treated you. So you don't, you revert back to that old way, and you've lost something in your relationship as a result. But when you've lost it, it's nearly too late. So how do we need to build up that resilience, or that ability to have those difficult conversations.
Yeah, and that's we have a whole session then on both with partners discussing that, and then on talking to medical professionals. Mm-hmm. So it does mean taking the pen out and the paper out, because if you get fatigued, you're going to forget and won't be able to articulate. So it might be saying, I've got 4 things, I'm feeling a bit tired, so I've written them down in case I can't articulate them. And having a copy for you and a copy for the person, so it might mean investing in a proper printer of that. But it's then about having what I need. So I think the practice for people today would be to leave here thinking that I need to start having I need conversations with people. This is what I need from you. Irish people aren't great at doing that compared to other, let's say, American cultures of that. So it'd be good to practice it even initially with, I need some help with this, with one person is very reliable. So you start to get into the actual approach behavior rather than avoidance behavior. Why don't we get curious about it, first of all, before we even get into the approach? Because it might frighten people so much to even just think. When I meet people, I might think about what I could ask them, what I might need from them, but not do it initially. So you start an internal process of thinking about I need, and then move into the place of saying, even from your children, if you're in a place of better power, Rachel, I need these 2 things, and practicing that, because it's you're right, it's a really awkward feeling, isn't it, to say that. Yeah. And particularly if it's about bowel habits or urination, or this brain fog you're talking about, and the fatigue. There's also perception of, does this person understand what MS is? And sometimes you have nurses who haven't read up, or doctors who haven't read up properly, and they go, what? And for example, if you've got cognitive issues, there's a really good pamphlet PDF on the MS Ireland's website. I got down myself looking at memory and attention, concentration difficulties that people can have, and to give that to your GP or to your nurse.
I've got 2 more questions here, Jonathan, as well, that I'd like to go through. Right. The first one is, I'm the daughter of and a family carer for a woman in her 70s who has progressive MS.
Okay. Yes.
Okay. I'm wondering if any advice can be given in relation to what I could do, both in the moment and later in conversation, when my mother doesn't accept help for having, say, a shower or getting into bed, opting for sleeping in a chair instead. I feel demoralized when she doesn't accept this help, and somewhat guilty. Yet I have been accused by her of being dominant towards her in the past. So of late, I have chosen not to push her. Yet sleeping in a recliner chair puts her at risk of falls, for example, when she had a fall a few days ago. So,
yeah, it's really, now what you're describing here is, and we've talked about it the last time, is that the caregiving comes from the attachment system, which comes from the fear system. So when you've got somebody who you love, who you're frightened will hurt themselves or is in danger, our caregiving system gets activated.
Mhm.
It's activated if we think they might be in danger. So the falling off the chair, that means that's there, which means that that system will never turn off until you know the person's safe. So till the next morning or whatever time, which can affect your own sleep and those things. It also means that if someone has asked you for help and you feel futility in the giving of help and the person goes no, I call it the Spider-Man kind of defense from the person who they aren't really asking for help. They're trying to get you into, they're frustrated themselves and feeling a burden on themselves, and they want to get into it, they want to vent and get into a rage with you, just to let it out. So it's caregiving and care seeking is part of a directional system. When you've been asked for help genuinely, you won't feel relief because your caregiving system is activated until the person gives that, oh, yeah, thanks, look. Mm-hmm. And then you go, I helped that person. Whereas a lot of the times with someone with progressive disability, you have to really change the view about how am I going to help? You're not going to cure it. And it's about what's good enough help for the person here. You need to state, I can't help you, Mum, if you sleep on this chair because I end up wrecked because I am terrified that you're going to fall. And you did have a fall last Thursday. What can we do about this?
And when do you have that conversation, Jonathan?
So it's about having the conversation once the person's had some sleep, and I can go, I am frightened here. This is impacting on me. I'm not going to be an effective helper, an effective daughter to you if you have me frightened all the time. That is not fair. And we do know that even with vaccine studies that carers, you being a carer there, a daughter of somebody who's got the progressive MS and who's in her 70s, that you won't get a good antibody response if you take a vaccine because you're going to be stressed and your caregiving system is not being assuaged. So we both need to be cared for, ask for help and get help, and that assuages our care-seeking system. But also for a caregiver, we can't be blocked and we can't be asked to become unreasonable situations. If this keeps happening, you won't be able to have your mother in the house. You're going to have to seek for care outside. That's going to be the reality. Otherwise, you'll feel so guilty if she hits her head and has a hemorrhage.
So I'd be afraid in a situation like that you would end up guilting the other person into a behavior, and that could create a whole other level of animosity. And there's another comment here. I have huge guilt about all the help my children have to give me. They do it willingly, but I feel guilty all the time. And this is the flip side of that question. So the cared feels guilty, but also the carer feels guilty because they cannot do what they need to do.
So this is, oh God, it's really, it's very upsetting. I find it, just internally I feel a kind of pressure on my chest. And if you feel pressure around here in the chest to your shoulders, that's guilt. That's where we hold guilt in our body. It means, and it really blocks us being our vitality and being our authentic selves. So if you notice these types of things, write it down on a piece of paper and see how it goes in a circle and it's never ending. So it's about saying, okay, drawing a line through in the circle, going, where in this circle can I stop and change? And saying, I need to, otherwise we're going to go on ad infinitum until I die in this place. And I'll be going around a bit like who's the Samaritan who took Jesus Christ's cross. So there's something about saying, okay, we're in this guilt circle and we need to get out of this. So we need to be more effective. How can you tell me what your needs are, Mom? If it's the daughter of the 70-year-old. And 70 is very young, but it depends how much the progressive MS has gone along. Look at the reality. The reality is you're falling, Mom. I'm very worried. It really upsets me. In fact, I'm not sleeping properly. And I don't want to get in your way because you're saying I'm going dominant. We have an attachment protest when our caregiving system isn't met or caregiving seeking system isn't met. We go into anger. We go, But when either someone's not giving us the right care or when we give care, it's frustrating. So be nice to yourself. You're just having a normal protest when your caregiving system or care seeking system is not working, but it's not met. Remember, it's a goal directed. It's a bit like when someone blocks their anger, they come out with all niceness and Pollyannish type way of thing. Until I get the person in therapy to get their anger out, they will keep going in that cycle forever.
It's like we have little volcanoes in us and we just need them to erupt. We need to lance the boil. And everything that you have said, and we're nearly coming to the end here, Jonathan, it's the conversation.
Yeah.
We need to continually to have that conversation, to have that dialogue, to have it in a space and in a place that is not attached with the problem that we're talking about.
Yeah.
I think. And I know myself, I try to have it if I go out for a walk, if we go out with my partner or whoever I'm talking to, away from the place where that event happens, so that I don't have those triggers.
Yeah. And one key thing for the person who asked that question earlier, or the people who are sitting, because I think we're all working on our own relationships. When that person bravely said that story, we all have equivalent stories of that, I'm sure.
Yeah.
But it's to say, okay, and there can be a gender bias in this. Women can go into what's being called upset, being teary, and rumination. Okay? And if you get relief from that, that means you're doing the right thing. If you get a sense of body relief, oh, that was good, I was upset there about that. And if you don't, and you keep on going to that situation, what's happening is you're going into your well-rehearsed, to the emotion that you're more at ease with. And I might be sitting and going, wait, I'm actually not feeling relief when I get upset about mom let me help her. And what you might need to do there is go to the opposite emotion, which is anger and assertion.
And we've hit 46 minutes, Jonathan, at this stage. We've really, and there's so much here that we can get into, and unfortunately we don't have the time.
Yeah.
And I wish we will follow up with this. There's no question about it, because I think there's so much we need to understand, but we need to understand about ourselves first.
Yeah.
How we react to these events, and then only then can we really have that conversation.
Yeah, and people could track themselves. For me, I was getting a lot of sadness at one stage. Then I felt a bit of loneliness. Then I felt overwhelmed with anxiety about having these conversations, because they're very difficult. And then the need for compassion came in, and maybe the need for different emotions and feelings if they aren't working.
Excellent. So, Jonathan, thank you very much for your time. And I have to thank Aoife Kerwin, and I also have to thank Aidan Larkin for making this a possibility. The next webinar is going to be on August the 26th, and it's going to be about what is new in MS research. I'll be speaking to Dr. Una Fitzgerald, and she is a researcher in the University in Galway, and she specializes in multiple sclerosis.
Brilliant.
So I'm really looking forward to that conversation to see what new therapies, because the therapies available for people with progressive MS are like zero. So hopefully there will be some new information coming from her about what's happening in research. And maybe if there's ways that we as patients can contribute to that research and to make it more effective. Thank you very much again, Jonathan, and I look forward to talking to you again.
You too. Bye-bye.
Bye now. Bye.